Hello, my name is Dr. Jana McHugh, and I'm a clinical research fellow at the Institute of Cancer Research in London in the United Kingdom. And I'm very happy to present updates today on the impact study and the profile study. The background of the impact study is where we have identified men with a genetic predisposition to prostate cancer and targeted screening for these men and for controls. We began recruitment in 2005 for those in the BRCA cohort. In 2009, we started a quality of life study. And then in 2012, with the study amendment, we were able to start recruiting those with mismatch repair genes associated with Lynch syndrome. We have completed 5 years of screening in the BRCA cohort and will be completing 5 years of screening in the mismatch repair gene variant cohort later this year. The aims of the impact study are to look at the incidence of prostate cancer in participants with raised PSA level greater than 3, to look at prostate biopsy rates and the positive predictive value of these biopsies, and also the tumour characteristics found on biopsy. We have 67 recruitment centres in 20 countries, as you can see on the map, and then our recruitment targets are as follows for the BRCA cohort, and then for the mismatch repair gene variant cohort, and those genes associated with Lynch syndrome. This is a study algorithm, so for men aged 40 to 69, they're invited to participate. They undergo annual PSA. Should the PSA rise above 3, they are offered a biopsy. The other inclusion criteria is that they not have previous personal history of prostate cancer. In the BRCA cohort, this is the breakdown of carriers of BRCA1 variants versus controls, and here are the BRCA2 carriers versus controls. In the Lynch cohort, we have 962 participants, and this is the breakdown of the carriers versus controls of MLH1, MSH2 and MSH6. We have carried out and published baseline findings in the BRCA cohort. We had almost 3,000 subjects with 228 baseline PSAs greater than 3 requiring action and 69 prostate cancers diagnosed. The positive predictive value of PSA triggered biopsy is higher for BRCA2 carriers than for controls, and also higher for BRCA1 carriers versus controls. The positive predictive value of biopsy for BRCA2 carriers was double that reported for a general population sample in the RSPC. 2/3 of the cancers detected in BRCA2 carriers were found to be intermediate or high risk, and the only cancers detected in men under the age of 50 were found in BRCA1 or BRCA2 variant carriers. We also published an interim paper on the BRCA cohort, and this was after 4 years of PSA screening, with 527 PSAs greater than 3 requiring action. We had 357 biopsies carried out, of which 112 were found to be malignant. BRCA2 mutation carriers have significantly higher incidence of prostate cancer versus non-carriers. They tend to be younger at diagnosis, and 73% of BRCA2 mutation carriers had intermediate or high-risk disease versus 40% in the non-carriers of mutations. We've also published a baseline paper on the Lynch cohort. So after 1 year of PSA screening, the mismatch repair gene cohort, we found that the prostate cancer incidence was greater in MSH2 carriers versus non-carriers, and they tended to be diagnosed with prostate cancer at a younger age if they were MSH2 carriers. Similarly, the prostate cancer incidence was greater in MSH6 carriers. Our numbers are low at the moment. but we did find that 85% of MSH2 carriers and 75% of MSH6 carriers had clinically significant prostate cancer, and further annual screening rounds are required to confirm these findings. We have also published a paper on the psychosocial impact of prostate cancer screening in those at genetically higher risk of developing prostate cancer. So this has been published on the BRCA cohort. We analysed data in 760 participants. The uptake overall was quite high, and the data confirms baseline findings and mirrors general population screening studies, that there are no clinically concerning levels of general or cancer-specific distress found within the groups, that cancer risk perceptions tend to reflect genetic counselling and knowledge levels are generally high. And now I'm going to talk about the profile study. So the aims of the profile study are to determine the association of genetic status with prostate cancer detection in men at genetically higher risk undergoing targeted prostate cancer screening, and to determine the incidence and aggressiveness of prostate cancer in 3 genetically high-risk groups. We'll also look at the association of biomarkers, including a polygenic risk score, with prostate cancer detection in these 3 high-risk cohorts, and the association of the MRI findings with the biopsy findings at baseline. The 3 genetically high-risk cohorts we've included. Our first group are those with a family history of prostate cancer. And to begin with, this was confined to those of European ancestry, as that was the polygenic risk score that we used as the study opened and had only been validated in people of that ancestry. We've since expanded this. The second group is for those of Black African and African Caribbean ancestry, and our third group are high-risk gene variant carriers, like those included in IMPACT. Our inclusion criteria had to be aged between 40 and 69 with no personal history of prostate cancer. Family history for the first group meant having a father or brother diagnosed with prostate cancer before the age of 70, and we've now been able to expand this to those of any ancestry. Our second group, we defined those of Black African and African Caribbean ancestry as having both parents and all 4 grandparents of that ancestry. And our third group, as I said, include the high-risk gene variant carriers, and this includes BRCA1, BRCA2, Lynch syndrome, and those having high polygenic risk score for prostate cancer. When participants enroll into the study, they have 2 study pathway choices. So they can decide to have PSA only and go on and have an MRI and biopsy if the PSA reaches a certain threshold as seen in the box. Or they can decide to go ahead with an MRI and prostate biopsy regardless of their baseline PSA. This is our first group, our family history group. We've currently recruited 617 to this part of the study, with 293 MRIs completed, 241 biopsies done, and 79 cancers detected. In our second group, those of Black African and African Caribbean ancestry, we have recruited 283, carried out 86 MRIs, 65 biopsies, and detected 23 prostate cancers. And then our final group, those that carry high-risk genes, and these can be people of any ancestry. We have 205 recruited, 33 biopsies completed, and 8 cancers detected so far. And just to look a little bit further into our second group, those of Black African and African Caribbean ancestry, we have completed 65 biopsies and diagnosed 23 prostate cancers. And this is the breakdown of Gleason score of those prostate cancers found. So 64% have a clinically significant prostate cancer with Gleason score 7 or above. As I said, the overall aim is to investigate the incidence and aggressiveness of prostate cancer in men at higher genetic risk in the 3 groups I've outlined. And we now have a new multi-ancestry polygenic risk score where our SNP panel is more expansive and accommodate some newly identified African variants or variants more commonly found in those of African ancestry, as outlined in the Conti 2021 paper and the Wang 2023 paper. And we plan to sequence germline DNA to aim to identify novel pathogenic variants or more common pathogenic variants found in those of African ancestry. These are my acknowledgements. Many thanks.